What a wonderful day to be in Washington, D.C. when we're expecting more than 95 degrees, right? But I tell you, I live in Atlanta, hot Atlanta, so we're actually used to this. We really like this type of weather. Today is our last meeting of the year of NAPA. And so we're very excited for this calendar year, August 5th, 2024, to be our fourth meeting. It's an exciting meeting because you get to hear what we've been thinking about and planning and making recommendations for. That's what this major meeting is about, the recommendations from all of our subcommittees. And so we're very excited to be doing that. So I'm Dr. Adrienne Mims. I'm family medicine, geriatric medicine physician. I chair this council, and I welcome you to be here today. And we're going to do introductions first. First, we'll do the people in the room here at the table, and then we'll do our council members who are online. So I'm going to go first to my right.
Good morning, everyone. I'm Helen Metzger, and I am chair of the Long-Term Services and Support Subcommittee.
Good morning, I'm Randy Bateman, chair of the Scientific Research Committee.
Hi, I'm Harleen Bierman, and I'm representing AHRQ.
Hi, I'm Erin Long, and I'm representing the Administration for Community Living.
Good morning, my name is Alicia Etheridge, and I'm representing the Centers for Disease Control and Prevention.
Good morning, I'm Maria Teresa O'Caffer, and I'm representing ASPE.
Good morning, I'm Frank Shoemaker. I'm representing NINDS.
Richard Hodis, Director of the National Institute on Aging and representing NIH.
Hi, I'm Tisa Sherry. I'm the Deputy Assistant Secretary for the Office of Behavioral Health, Disability, and Aging Policy in ASPE. I'm also currently performing the delegable duties of the Assistant Secretary for Planning and Evaluation. Good to see you all.
And good morning, everyone. I'm Helen Lamont. I work in ASPE, and I am the designated federal officer for the Advisory Council. Sure, let's go online. Let's start with our non-federal members. Brother John Richard.
Hello, my name is Brother John Richard. I am an individual living with Lewy body dementia and a member of the Alzheimer's Council.
Thank you. Ken Kim.
Good morning, name's Ken Kim, serving refugees and immigrants at the Health Center.
Morning, Ken. Rhonda Williams.
With the Vermont Department
Rhonda, you're
of Health.
muted. Oh, try again.
Okay. Sound good? All right. Rhonda Williams with the Vermont Department of Health, and I'm here representing public health.
Thank you. Susan.
Good morning, everyone. I'm Susan DeMorris, the Director of the California Department of Aging, representing state units on aging.
Welcome. Now we're going to switch to our federal members. Amy Kelly.
Hi, this is Amy Kelly. I am the Deputy Director at the National Institute on Aging. Good morning, everyone.
Thanks, Amy. Bruce Fink.
Good morning. This is Bruce Fink from Indian Health Service, and I'm joined also by Dr. Jolie Crowder, also from IHS, from the Alzheimer's team. And for some reason, I don't look like I'm on video, but I'm going to try to come back on and try to get the video working.
Thanks, Bruce.
Thanks, Bruce.
Ellen Blackwell.
Hi, I'm Ellen Blackwell, and I'll be representing CMS this morning.
Thank you, Ellen. Jolie, would you like to introduce yourself? Bruce kind of did.
Good morning, everybody. Thank you.
Sarah Fontaine.
Sorry about that. Good morning, everyone. I'm not going to turn my camera on as I'm not feeling quite the thing, but I'm Sarah Fontaine. I am the program manager for the peer-reviewed Alzheimer's program at CDMRP within the Department of Defense.
I believe last but not least, Scott Harcroft. Okay, he may have stepped away from his computer, so I'll turn it over back to you.
Okay, thank you. Thank you and welcome everybody for being here with us today. We're very excited that you've made the time in your schedule to do this. As you look at the agenda, after we do federal updates, we may have a little brief a break, but then we're going to go into a wonderful presentation by Tanya Safer about the GUIDE model. We know that it has launched, and we want to really hear an update on that. And then the rest of the day is going to be broken into our subcommittees. We'll start with the clinical subcommittee. We'll have lunch, the research subcommittee, then we'll do the long-term services and support, a break, and then the risk reduction. What we did differently this year compared to prior years is we know it's a little challenging to just listen to recommendations all day. So we've interspersed each section with a late-breaking or new presentation. So we think that you'll be energized and excited to hear those new presentations today. So I'm going to turn it over to Helen so we can start with the federal updates.
Great. So thank you, everyone. We have slides that are loading in the room, so I have a clicker I will pass. If you're online, just say next slide, and we can fast forward, but give us a second to move the clicker around. Our order today is ACL, AHRQ, ASPE, CDC, CMS, FDA, IHS, and finally NIH. So we have a lot of agencies presenting, and we have 88 slides in 1 hour, so I asked my federal colleagues to move at a pretty rapid clip so that we can get through everything on the timeline that we have set this morning. So with that, do we want folks at the podium? Or table? No? Okay. All right, so I'm going to turn it over to Erin and walk the clicker to her. Go ahead, Erin.
Oh, this slide is not. Oh. No.
Oh, okay. So I just have a couple quick items to talk about from the Alzheimer's Disease Programs Initiative that we are operating at the Administration for Community Living. I just wanted to give an update on our Innovations in Respite program. In November, we funded the Alzheimer's Association, and they created the Center for Dementia Respite Innovation. And that's a partnership between the Alzheimer's Association, the University of Minnesota, and the School of Public Health, the University of Minnesota School of Public Health and US Aging. In July 2024, they announced the award of more than $4 million in grants to 21 community-based service providers to increase the availability of quality and dementia-specific respite care. There's 2 links here to the Alzheimer's Association site so that you can check out their press release. Next slide. Just wanted to give an update on a new upcoming webinar we actually have next week. It's very exciting, talking about the dementia-friendly Clark County, Nevada programs that they have going on. They're going to, the cool thing that they're doing there is they're training TSA to help people with dementia at the security checkpoints, and so they're going to be talking about that as well as their dementia friendly initiatives, but the cool thing is the person from TSA coming. We also have later in August, we have a webinar with our grantees that are doing cognitive stimulation therapy. They're doing it in person and online, and including people with intellectual and developmental disabilities. It's very very good work that's happening in that realm, and there's the opportunity to, in the slide you have the opportunity to register. Just quick update on some previous things we've done. We did a webinar for our grantee in Puerto Rico, talking about their risk reduction efforts and an intervention that they created that is a series of 12 activities, which is very well received in Puerto Rico and getting more people engaged and more older adults thinking about ways that they can protect their brain health. The last webinar that I want to talk about is the one that we did in June, which was focused on tribal communities doing interactive programming through the virtual dementia tour. We've been working with the tribal grantees since 2020. Everybody's found their stride, and they are doing the VDT, which is an experiential intervention that people are really responding well to, and uptake is huge. And now it's gone from one tribal entity to 5 out of the 6 that we funded have realized that it's going to reach a lot of people. Just some new resources that we have. We maintain a list of our evidence-based and evidence-informed interventions that are created by our grantees. I'm not going to go through them all, just various language, translated, interpreted materials, caring guides. These are just new things that we've put on our NADRC website. And then I just wanted to highlight one resource that I'm particularly proud of. Our grantee, Great Lakes Intertribal Council, created 2 videos, one animated and one with interviews. A Day in a Life with a Tribal Dementia Story is an amazing perspective for a tribal woman and man in their journey through dementia, and it's an amazing tool to be able to use in education and risk reduction. And then In Our Own Voices is interviews with caregivers in tribal communities. So there's the links there. You can go check them out on YouTube and on the Glitzy website. And with that, I'm done. Arlene?
Good morning. So I have a few updates from ARC. We don't do anything that's dementia specific, but our work has improved. It's on delivering person-centered care to older adults, many of whom have cognitive impairment. And so we just released a strategic plan that we've been working with. And I've talked to many of you. We've gotten input from our federal partners on where is ARC's unique niche. But it's called Advancing Health System Transformation to Optimize Health, Functional Status, and Well-Being Among Older Adults. It's posted on our website, and the link is there. And basically, we have 5, objectives. One is this is what ARC does. So we fund research to develop, implement, evaluate, and scale models of care. We disseminate and implement evidence. We do a lot of implementation science and implementation research. We support training and mentoring, so ARC does fund, people are not aware of that, but we fund K awards, dissertation awards. We have P30s for embedded researchers, and we would love applications from people who are interested in, cognitive decline and dementia. And we also, we've been working internally, too, to expand and create synergies across all our programs at ARC. ARC, like any other federal agency, is siloed, and it's been great to, get together with people working on aging-related issues across the agency. And we're also trying to develop partnerships. I'll talk to you a little bit more about that afterwards. We put out a special emphasis notice a few months ago on improving care for older adults. And basically, the special emphasis notice conveys ARC's interest in supporting health services research to conduct research that will address questions related to the development, implementation, evaluation, and scale of person-centered models of care. So please, spread the word. We're looking for those sorts of applications. This is very exciting. ARC, through the Patient-Centered Outcomes Research Trust Fund, we have a notice of intent, but the NOFA will be published in the near future on health care extension services. And these are state-based collaboratives aimed at improving care. And we'll fund about 15 state-based healthcare cooperatives across the country, a national coordinating center, and a national evaluation center. And it would be wonderful if some of those states are focused on older adults. Actually, I'm going to skip this slide, but I just want to show, this because this is why it's so hard what we're doing. I read, the recommendations from the committee, and we've been working on this for a long time, and really the need to align policy, payment, culture, and then have the evidence for how to do it right. I've presented to you about our e-care plan in the past, which is an interoperable Smart on Fire app that allows aggregating data across multiple EHRs to support care planning and care coordination. And I'm just putting this up because we've been sponsored by HL7, and we've developed the data standards for interoperability. And this should be posted as, a formal HL7 implementation guide imminently. It's been approved. And then the last thing I'm going to mention is we have a National Person-Centered Care Planning Initiative, which is going very well. For time, I'm not going to go through this. You have the slides. But it includes a technical expert panel, a partners roundtable, and a learning community, and the engagement we've had from people across the country and the enthusiasm. And, what we're learning is there's so many people doing great work, innovating in their own, practices or communities, and bringing people together. I think we can really accelerate change.
Hello, everybody. I'll provide the updates for on behalf of the Office of the Assistant Secretary for Planning and Evaluation, or ASPE. Briefly, we just wanted to highlight for this group a couple of recent ASPE research briefs that have been published since the last meeting that relate primarily to long-term services and support settings in which older adults, including people with dementia, may receive care and which serve as a critical source of support for those individuals. The first brief that I will highlight relates to one set of those LTSS settings, nursing homes. We published a study earlier this year examining changes in ownership of skilled nursing facilities between the years of 2016 and 2021. This was using publicly available data from CMS that identifies nursing homes that experienced a change in ownership, which could be a merger and acquisition, for example, but there are many other potential types to consider as well. And part of the reason that this work was undertaken was because there's an accumulating body of evidence suggesting that ownership structures of nursing homes and also changes in those structures can have implications for the quality of care that residents receive. So the goal of this brief was to better understand some of the characteristics of nursing homes that were frequently undergoing those sorts of changes. What we did find was that facilities that were more likely to experience changes in ownership tended to be medium-sized as opposed to very small or very large facilities. They tended to have low occupancy rates, and they also had incurred more fines. So together, this preliminary data helps paint a picture of what types of facilities may be a little bit more vulnerable to some of these changes, which have the potential to be disruptive to residents. The second brief focuses on a different set of LTSS settings, which is Medicaid home and community-based services. In this brief, what the team did was examine HCBS waiver policy flexibilities that were taken up by states during the COVID-19 public health emergency to try to maintain access to home and community-based services at a time when many people were trying to move out of nursing homes. And so there was increased demand for services in the community. A number of states put in place these flexibilities, and so the team interviewed state agencies and also HCBS consumer and provider groups from 9 states about their experiences with these flexibilities. They sought to understand why they chose to implement them, what the experience was like, and whether they'd undertaken any evaluation activities. Briefly, at a high level, in terms of selection, what we learned from state agencies is that they relied mostly on some of their prior experiences with these policy flexibilities in other settings, settings to determine what they wanted to implement during the COVID-19 PHE. In selecting policy flexibilities, they were informed heavily by feedback from HCBS provider and consumer groups. Also were guided by priorities around health and safety concerns for people with LTSS needs, and in a number of cases were also selecting them in an attempt to try to address workforce shortages that were exacerbated during the pandemic. They identified several challenges with implementation, including uncertainty around how long these flexibilities would still be permitted by the federal government, delays and challenges in accessing and interpreting the guidance that they were receiving around flexibilities, also having limited state infrastructure to support these changes, and uncertainties with provider payment. Taken together, all of this information is really helpful to us as we try to understand how to better support our partners in state government in implementing these changes to help expand access to LTSS for older adults, including those with dementia. That's all.
All right, so now I will give a few updates. And again, I'm Alicia Etheridge. I'm the lead of the Alzheimer's disease program team at the Centers for Disease Control and Prevention. So the first big update is that there is a new publication scheduled for release in the Journal of American Geriatric Society this Thursday at 10 a.m. Eastern. So this is a collaborative study between the Indian Health Service, CDC, and the Alzheimer's Association. It's the first to provide estimates of dementia, including Alzheimer's disease, among American Indian and Alaska Native populations who received medical care through the Indian Health Service. All right, so now I'm going to share with you some of the really fantastic resources that our funded partners have developed over the past 3 months. So CDC provided funding to the American College of Preventive Medicine to develop educational tools and continuing medical education opportunities for healthcare providers, really focusing on the connection between lifestyle medicine and brain health to evaluate dementia risk reduction strategies and increase these providers' awareness of Alzheimer's disease as a serious health concern. So one of the tools that they created was just released, and it is the Community Clinical Linkages to Promote Brain Health Toolkit. So this toolkit offers a structured approach to educate patients about Alzheimer's disease, mitigate risk factors, and to promote cognitive function through strengthened community clinical partnerships, which we know are really important. This is really cool because it provides not only actionable guidance, but case studies and educational materials to support the integration of brain health initiatives within health systems. So we're really encouraging all of our public health partners and those interested individuals to use this toolkit as a way to foster collaborative efforts towards healthy aging and improved patient outcomes in brain health. All right, another really cool resource that the American College of Preventive Medicine put together were 2 new courses on brain health. The first is Improving Brain Health, a practical review of dementia risk reduction strategies. The other is Heart Healthy is Brain Healthy, Cognitive Decline and Dementia Risk Reduction through Blood Pressure Control. So both of these courses are really designed for our physicians and healthcare providers and helping them to identify risk factors in patients and share effective management strategies specifically associated with mild cognitive impairment and Alzheimer's disease. So feel free to check out these 2 courses using the links that are on the slides. All right, next up, we have a partnership with the American Medical Association, and they hosted a 3-part webinar series called Navigating Brain Health, Alzheimer's and Dementia in collaboration with CDC and the Alzheimer's Association. So the webinars included experts who explored really critical aspects of Alzheimer's disease, and they provided some best practices and strategies specifically for screening and diagnosis, risk reduction, and treatment. So you can access the recordings from these series at the link on the slide, and also there is continuing medical education credit available for those courses. All right, so now I will share with you some work from the Alzheimer's Association, who is funded under our National Healthy Brain Initiative Cooperative Agreement. So they have opened applications for the next cohort of the HBI Roadmap Strategist. This is a really fantastic program that increases the capacity of local health departments and their community partners to address cognitive health, and all of the participants in the program become part of this select group of change agents from across the nation who are really working to address dementia using this public health approach. So this program is hosted in collaboration with NACCHO. It's a year-long program, and they provide funding for up to 10 local health departments, along with education, peer support, and technical assistance. So applications are due September the 26th. You can visit the application link using the QR code on the slide, and the application page also has additional information about the opportunity. All right, another really fantastic resource that the Alzheimer's Association has released is a new infographic called Alzheimer's and Public Health Issue. This is a really great, tangible one-page resource that highlights the role of public health in promoting brain health, increasing access to early detection, and supporting individuals living with dementia and their caregivers. All right, next up, I know you guys have heard a lot over the past couple of meetings about the update of the roadmap for Indian country. This first roadmap came out in 2019. We're now in the process of updating it. It has since been renamed the Roadmap for American Indian and Alaska Native Peoples. So CDC and the Alzheimer's Association are continuing to make progress on this update. We have a full draft of the roadmap that has now been reviewed by not only our leadership committee, but also the federal liaisons. So we're currently reviewing those comments and also preparing to work on the cover, selecting some of the graphics to be included in the document. The Alzheimer's Association also has a really nice progress update, and it's linked on the slide. It's a one-pager that summarizes the systematic approach that's been taken to update the document, including the input gathering and the broad engagement from multiple sectors and groups, including listening sessions with tribal leaders and communities. So that roadmap is scheduled for release in November of this year. All right, now I'm going to share some updates from our BOLD Public Health Centers of Excellence. Just as a reminder, these recipients are currently in year 4 of a 5-year cooperative agreement period. So first up is our BOLD Center of Excellence on Dementia Risk Reduction. They've been really busy putting together a really great webinar series focusing on social determinants of health and dementia risk. So the first 2 webinars were very engaging, and there's still an opportunity to participate in the last 2 webinars in that series. The next one is August the 24th on Breaking Barriers, Combating Dementia Through Social Engagement, and it features Dr. Crystal Glover from the Rush Alzheimer's Disease Center. They also have a series of infographics that are looking at modifiable risk factors for dementia and the ability to address those risk factors that are affected by social determinants of health. And lastly, they have also released 3 new videos on modifiable risk factors for cognitive decline. And each of these videos feature experts from the Alzheimer's Association and the Rush Alzheimer's Disease Center. And so the presenters share scientific evidence on diet and nutrition, cognitive engagement, and mild traumatic brain injury. And they also talk about the implication for public health, showing the need for effective risk reduction strategies across the life course. So you can check out those videos using the link below. All right, next up is our BOLD Center for Early Detection of Dementia. So they have a lot of resources available, including this new toolkit for health systems. They also offer a series of conversations about interventions that promote earlier dementia detection as a pathway to better care and outcomes. And so, as you can see from the stats on the slide, their past 4 webinars have really generated a lot of engagement, particularly with new audiences. All of their webinars are recorded, and something cool that they have are these webinar excerpts. So if you don't have the full hour to devote to watching the recording, you can view a little 5-minute clip where the speaker from the webinar talks about the key takeaways in the field of early detection of dementia. All right, and so this slide just showcases one of the highlights of their recent webinars on linking statewide dementia screening to diagnostic social services. Next up is our BOLD Center of Excellence on Dementia Caregiving. They have this really great roundtable series that they offer, successful public health approaches in dementia caregiving. And in each episode of the series, they highlight the story of one state that has successfully implemented a statewide, innovative, and integrative approach to advancing its dementia caregiving goals. So each session starts with an overview of the state's caregiving efforts, followed by an interactive conversation, and then a Q&A with the attendees about key takeaways and really some ideas for actions that they can go back and potentially implement in their own state and communities. So this series is a great opportunity for peer-to-peer sharing, knowledge exchange, and idea generation. So the next roundtable that they have coming up is August 14th, and it will feature New York State. So they also just launched a new toolkit on July the 24th, and it is Disseminating Evidence-Based Programs to Support Family Dementia Caregivers, the Role of Public Health. As part of that release, they hosted a webinar on July 24th as well, focused on key actions public health agencies can take to disseminate supportive programs and resources for caregivers. It also highlighted the crucial role of public health in ensuring accessibility to these services. And a special shout out to our federal partner, Erin Long from ACL, who served as a panelist during that webinar. And so the recording is available at the link below. All right, and so this is just a lot of the coming soon in the pipeline for the Dementia Caregiving Center. All right, so next up, there's something wonky going on with the font on the slides. It's a different font. All right. Okay. All right, so next up we have our Healthy Brain Initiative Component B recipients who support populations with a high burden of Alzheimer's disease and related dementia to develop and implement public health strategies that are guided by our HBI Roadmap series. So Us Against Alzheimer's, they support our Black and Latino communities, and so they're implementing this phenomenal program. It's the Brain Health Equity Nurse Fellowship Program. It's designed to address disparities in knowledge, access, diagnosis, and treatment among African Americans and Latino people. So they partner with the National Black Nurses Association and the National Association of Hispanic Nurses on this program, and it really empowers nurses with the knowledge and public health leadership skills that they need to promote brain health in communities with a high risk for ADRD. They also just launched a 2024 digital ad national campaign on July 19th. And so this campaign is going to disseminate ADRD prevention messages with a specific call to action. And they're focusing on 13 counties where priority populations are disproportionately impacted by ADRD. All right, next up is the University of Illinois at Chicago, and this program is funded by CDC to support individuals with intellectual and developmental disabilities, and they're implementing the Virtual Health Matters program, so this slide just lists some of their accomplishments over the past few months. They are also working with the National Task Group on Intellectual Disabilities and Dementia Practices. And one thing I want to point out on this slide is that they were recently awarded funding by the Special Olympics program for a new project to supplement the guide work by providing tailored training, education, information, and technical assistance materials to really enhance the reach and capacity of guide model sites to provide high quality care to adults with intellectual disabilities and their caregivers. All right, so we have a new Healthy Brain Resource Stories from the Field posted on our website. And this is a series of stories that highlight the work of our BOLD and Healthy Brain Initiative grant recipients. The newest story highlights the Mississippi BOLD Public Health Program and their work to address social determinants of health that influence the incidence and mortality rates of ADRD. So be sure to check that out at the link in the slide. And last, I just want to end with a spotlight on one of our BOLD public health programs. And you guys may recall we fund 43 state and local public health agencies through our BOLD public health programs. And so the Virginia Department of Health, they awarded 4 mini grants to enhance community education, caregiver training, and the development of a state-of-the-art dementia registry, the Virginia Dementia Patient Registry. And so this registry really provides valuable insights into dementia prevalence among different groups. And by leveraging this information, social and medical services can then be tailored to meet the specific needs of individuals living with dementia. So we're really excited about the work that Virginia is doing along with our other 42 BOLD public health programs. And with that, thank you.
I'm sorry about the slides. I'm reformatting the afternoon slides. Upstairs, we're widescreen. Here, we're a narrower screen, so apologies for the formatting. And thanks for your flexibility. As always, will you guys pass that over? Next, we have CMS, and Ellen Blackwell is going to walk us through these slides. So Ellen, just say next slide, and I'll fast forward.
Is the first slide up, Helen? Because
yes, should be.
Okay, yes, next slide. Okay. There we go, practice. Okay, so our first slide talks a little bit about the gargantuan regulation that CMS issues every year that governs physician payment, and drawing it to your attention because there are a few proposals in this year's regulation that the group might be interested in. One is a refinement to the new caregiver training services that proposes training and supports for certain activities that unpaid caregivers may render, and also behavior management and modification training, which may have particular relevance for people living with dementia and their caregivers. The second is, more of an umbrella RFI. We're trying to understand if there are issues or improvements we could make to the new services that went into the physician fee schedule last year: community health integration, principal illness navigation, and the social determinants of health risk assessment. And the last is, there are, by the way, there are many other proposals in this regulation, but these are the ones that we just wanted to flag. Safety planning for people who may be at risk or who have attempted suicide. So, the part in yellow is important because public comment ends on September 9th. So there is still time to get a comment in. And I can assure you that we read every single comment and try to respond in the final rule. So the link is here and you are welcome to comment. The regulation is over 2,000 pages. The easiest thing to do when you're looking at it is to maybe, issue a fine command for anything that is of interest, but we welcome comments. Next slide. So the next regulation we wanted to draw to your attention is the regulation that governs payment for hospitals. And we finalized this regulation for 2025 last week. And just letting you know that there is a measure that will go into effect in 2027 for payment determination. And this is a measure that you may already be familiar with because the age-friendly 4Ms rubric sort of overlays all work on older adults. And hospitals will be looking at things like, the person's goals, frailty screening. I mean, you can see them here. I know, Helen, you said we were a little short on time, but again, you can click the link and you can run a search command and you can take a look at more on this particular measure, which is now in the final regulation for hospitals. Next slide. So just a couple review updates on the national coverage determination with coverage with evidence development for monoclonal antibodies related to Alzheimer's disease. And, most of this is information that is already familiar to this group, but we wanted to make sure we noted that Kisluna was added just last month, the same day that it was approved by the FDA. Next slide, please. And this is just kind of a review of the rules around the CED studies and, who can participate and what the requirement is for clinicians to, submit data on individuals. There are currently 3 studies under the NCD, and since July of 2023, We have collected thousands of entries across every state, and even more people may be participating in any of the 3 additional approved studies. So always more to come on this, but that's sort of a status report. Next slide is we haven't talked a lot about antipsychotics in nursing homes recently, but CMS continues our work to reduce the use of unnecessary antipsychotics in the nursing home setting. We are monitoring these. You can see the results on the CMS Compare website, that applies to nursing homes. And we have had a particular concern about perhaps individuals living in nursing homes who are misdiagnosed with schizophrenia, possibly to be able to administer an antipsychotic. And we wanted to just note that we are, continuing to monitor this. Next slide. And we do this in some cases through special audits. And if a nursing home fails an audit, there could be multiple reasons, but we do expect the nursing home to make corrections. And really, this is just to let you know that we are continuing to look at this issue. It is not dormant, and make sure that people are getting the medication that's right for them. So that is all we have today. Thank you.
Thanks, Ellen. Teresa, over to you.
Okay, hi. This is Teresa Bracchio from FDA. Are the slides up? I can't. They're there. Okay. We can go to the next slide. So this was just touched on in the CMS summary already, and I think everyone is well aware that donanemab, which has the brand name Kisunla, was received traditional approval on July 2nd, and this was based on results of a phase 3 randomized controlled study, and also we did utilize data from the phase 2 study to support our decision. This was also, I don't have it on the slide, but it was also discussed publicly at an advisory committee meeting on June 10th of this year. We can go to the next slide. I'm just briefly going to comment on the data that was used to support this approval. And this is a really dense slide, and I'm not going to read through it all. You can look at it later in your leisure. But this was a 18-month or 76-week phase 3 study that was multi-center and adequate and well-controlled. It enrolled patients who met criteria for mild cognitive impairment or mild Alzheimer's disease due to, or mild dementia due to Alzheimer's disease based on confirmed presence of amyloid pathology. And there's a couple unique elements to this study. One is that they used an enrichment strategy based on tau PET imaging to enroll patients who had enrolled patients that had low, medium, and high tau levels on PET imaging. And then the other unique element of this was that they used a unique dosing regimen where they essentially monitored patients with amyloid PET imaging and stopped dosing once amyloid PET levels decreased below a pre-specified threshold level. And so the results of this study were robustly positive and statistically significant on all the primary and secondary endpoints. They did use an endpoint called the IDRIS, which is a combination of the ADAS-Cog13 and the ADCS-ADL. They did show benefit on the IDRIS and both of its component elements in both the low-medium, pre-specified low-medium tau population and the overall population that showed that also included the higher amyloid burden. They also showed a benefit on the CDR sum of boxes in both the low-medium tau populations and the overall population. And this was supported by change in brain amyloid plaque levels on PET. We can go to the next slide. this is actually the phase 2 study, and as I mentioned, we did leverage data from this study also in our action. We consider this, even though it's a phase 2 study, it was still designed as an adequate and well-controlled study, which was randomized, double-blind, and placebo-controlled. It had a similar design to the phase 3 study. It was just smaller, and because of its smaller size. It did show trends on all of the endpoints and showed the same magnitude of effect as that seen in the phase 3 study, but the statistical significant results were on the primary endpoint of the iADRS and then on the brain amyloid plaque reduction. And and safety is generally comparable across the two studies, which I think I'll talk about on the next slide. So we can go to the next slide. So the safety in the phase 3 studies was generally consistent with what we've seen across this class of drugs that are targeting monoclonal antibodies that target amyloid. We saw that ARIA, headache, and infusion-related reactions were the most common reactions. ARIA taken together to include both edema and hemosiderin deposition was observed in about 36% of patients. Compared to 14% of subjects on placebo. But if you break that down and look at ARIA-E alone, it was about 24%, and ARIA-H, although there is co-occurrence with these two findings. And about 6% of patients who had ARIA, in those patients, it was symptomatic. There were 3 deaths associated with ARIA, with one of those being caused by an intracerebral hemorrhage. And their overall incidence of ARIA was higher in ApoE4 homozygotes compared to non-carriers and heterozygotes, which is also known for this class as well. We can go to the next slide. In the prescribing information, we use the same indication statement as we've used for both lecanemab and aducanumab. Which is that it's indicated for the treatment of Alzheimer's disease, with a specifier being that it should be initiated in patients with mild cognitive impairment or mild dementia stage of disease, which was studied in the clinical trials. Dosing, this was one of the things that was discussed at the advisory committee meeting was the dosing regimen, and we heard clearly at the advisory committee meeting that although there were uncertainties about the optimal duration of dosing, that some clinicians did feel that the ability to stop dosing earlier would be attractive to some patients and some prescribers as well, that they could still see benefit in being able to reduce risk of progression of symptoms, but that it would minimize burden to patients, and that there may be some patients who for them that's enough to just reduce the risk at the time of dosing and may not wish to consider dosing. So given that, we did put in the labeling that prescribers and patients could consider stopping dosing based on reduction in amyloid plaque levels. Amyloid PET was what was used in the studies, and that's all we have data on, although I think additional work will need to be done if there is other monitoring that can be used to help inform a decision to stop labeling. One of the other things I forgot to mention in the indication statement was the piece about tau PET imaging. And although the only enrolled subjects who were low tau to high tau positive on PET, and those subjects who were negative or very low tau on PET imaging did not get randomized, but were enrolled in an open label extension. So that was also one of the discussion questions at the advisory committee meeting, is whether there was data to support dosing for patients with mild cognitive impairment or mild dementia, irrespective of findings on tau PET imaging. And in general, there was support that the tau PET, although it was used for an enrichment strategy in the trials, did not necessarily need to define the population that would be indicated in the labeling. And we did agree with the advisory committee on that. So Although tau PET is described in section 14 of the label, which is a description of the clinical trials, it is not in the indication or dosing recommendation section as a criteria that is needed to inform use of donanemab. We can go to the next slide. And then as far as prescribing information, we've already had a boxed warning for the risk of ARIA and the potential for serious outcomes in a labeling for lecanemab and aducanumab already. So we would also, and we consider that a class labeling. So we also use a box warning in the donanemab label. The new risk that was identified during the donanemab review was that ARIA-E can cause focal neurologic deficits that can mimic an ischemic stroke. And so that is important for treating clinicians, particularly in the emergency setting, when these patients would present in an emergency room or to emergency personnel, that treating clinicians need to be aware of this to avoid giving inappropriate thrombolytic therapy if there was concern for stroke, that an additional workup for the etiology of the symptoms may be needed. We also consider applies to all of the drugs. It's really a warning more about ARIA than the specific drug. So we would consider that safety signal to also apply to lecanemab and aducanumab. The increased risk of ARIA in ApoE4 homozygotes I've already described and was already in the box warning, and then also a contraindication for serious hypersensitivity to donanemab, and that's I think that covers everything. I think that's the last slide. Okay, yep. Thank you.
Thank you so much. I'm not supposed to go too close. Next we have IHS. I don't know if it's going to be Bruce or Jolie or maybe both. Over to you.
I think I'll take this one, Helen. Do you have slides for us? If you don't,
yes.
It's my oversight.
Yes, they toggle off you. Every time we switch people, they toggle off to move the camera. But
okay. I'm sorry, and I need to. Oh, there we go. Okay, we'll slip through in the interest of time. To the next slide. I'm not going to repeat. I'll be brief. This is really just an update. Next slide. You've seen some of these slides before. We sort of build them in as an ongoing update. And here's where we get to sort of what's new. So we have completed our round of 2024 grant applications. They're in review currently. We had a very good response. Just as a reminder, the 2024 applications or NOFO was slightly different. The 2022 and 2023 awards were from sort of beginning at ground zero, building a comprehensive approach to care for people living with Alzheimer's, with dementia and their families. The 2024 is about programs that have already gotten some work started in some of the major areas. And we had a very good response. And these grants will be focused on kind of further building that work out and building towards sustainability over time. We look forward to announcing in the next month on the awardees for the 2024. We have allotted funding for up to 6 grantees in that cycle. So the next slide. Further updates on our workforce development and capacity building. Our 2 main areas, again, are both in the tribal grants that get money straight out to tribal and urban Indian health programs, and then in the workforce development and capacity building, also aimed at IHS, tribal and urban Indian health programs. We had our 3rd round of Indian health geriatric scholars. We just completed that application. There's 24 applicants. For the 2024 cohort, largest we've ever had, and we're just opening the doors, going to include all of them. One of the exciting features of the applicants this year is that we have several that are coming from some grantee programs. So we're starting to see synergy between our programs, where the grants focus tribes and urban programs on developing services. That helps them then think about what kind of workforce they need for that care, and they're taking advantage of the workforce development capacity building programs we've put out. We have completed the first year work with the Geriatric Nurse Fellowship. 16 advanced practice nurses, RNs, and LPNs completed that work and shared their work with each other at an in-person meeting. We continue the work around the Indian country dementia echoes with the Northwest Portland Area Indian Health Board on a monthly basis, and that audience continues to grow. The oral health program has completed a second round of pilot programs with oral health programs, incorporating the tools for dementia detection and recognition into oral health care, and issued a report on that. I think they're hoping to continue that work as part of their array of work in which they integrate care across oral health care with other aspects of health care, both behavioral health care and clinical and medical care. We are continue to partner with the Oklahoma University Dementia Care Network, which is GWEP funded. So it's HRSA's GWEP program to support dementia training for the IHS and tribal community health representatives as they build the ability for dementia detection into their services. They're out in the homes on a regular basis, and we're excited about this partnership. And it's again part of that synergy between existing federal programs that helps us bring more resources to the tribes. And finally, the Geriatric Emergency Department Accreditation Initiative continues in partnership with the IHS Division of Nursing, both opening up to additional IHS or tribal EDs that would like to seek a bronze level certification, but also to support sites that want to advance their certification to silver or gold. Next slide. I'm not going to go into a lot of detail here, just we also continue our work in outreach and awareness more broadly speaking. This is really a continuation of some of the work we've reported on in the past. In terms of the programs that support data, Alyssa stole the thunder on the shared work with CDC around analysis of IHS data from the National Data Warehouse, and also our Purchase and Referred Care program to look at the rates of of dementia diagnosis for those American Indians, Alaska Natives who use IHS-funded services, either tribally delivered, urban delivered, or through IHS. We're really excited about that paper that's coming out again just in a few days. A little bit about what it says and a little bit about what it doesn't say. It is not a true prevalence paper. It looks at the equivalent of claims data, basically the clinical data we have that is reported to our National Data Warehouse around dementia diagnosis. But it's not so that's folks who are using IHS or tribal services either directly or through purchase and referred care. It's not a true population prevalence data, but what it is, and it's really important, is that it provides us with a baseline to look at the rates of diagnosis in dementia in IHS and tribal and urban programs funded through IHS. And it will be very valuable as we move forward into the future and continue to build capacity and capability in IHS tribal and urban programs and in the workforce to recognize dementia, cognitive impairment, to make the diagnosis, to get folks into care. And we expect to see those numbers actually increase over time. And this is really going to be very important baseline data for that. Next slide. And I think that's it for the brief summer update. Thanks.
Great, thanks, Bruce. I am going to now share my screen for NIH, and we will see if that helps with the formatting issues. Let's see. Always flexible here, guys. Share screen. Okay. Can you guys share to me? Got it. It's not on here, so. Okay, Dr. Hodes, over to you. Just say next slide, and I will fast forward on my own computer.
Will do. Thank you. So at this meeting's presentation, what I'm going to be emphasizing is the presentation to you of the Alzheimer's and related dementias professional judgment budget for 2026. The next slide, please. And next. Just to remind folks what this constitutes, this is a requirement by law each year through fiscal 2025 next year that the director of NIH, this year Monica Bertagnoli, present to the president for comment, but not for any alteration, a professional judgment budget presented to Congress which illustrates the resources needed to pursue fully the goals of the national plan. The plan is forwarded, and with this opening of the meeting today will go public. Next slide, please. Just to give you an idea of the way and process by which we derive the plan, it's an attempt to be quite transparent, inclusive, and informed, and it begins with input at many meetings, including the summits that we hold, which have contributions from academic researchers, other federal agencies, non-government organizations, individuals living with dementia and their care partners. On the basis of all this input, each year we constitute a series of milestones, which are the events that need to be accomplished in order to achieve the goals of the national plan. There is then discussion at NIH about how all of these translate into the cost needed to accomplish each of those milestones. Criteria for success of the milestones is included. This is all then aggregated into a total and plan that proceeds for the final professional judgment budget, in this case an estimate for FY26. And the next slide, please. The format for this budget is a common Alzheimer's disease ontology that was generated over past years in collaboration with the Alzheimer's Association. It provides an overall framework for organizing the goals toward the national plan. And it also provides a framework for IDROP, the International Alzheimer's Disease Research Portfolio, which allows tracking of all the research from U.S. and other foreign entities, private sector, in their efforts at Alzheimer's-related dementias research, all to the effect of helping to identify gaps and coordinate efforts in these areas. So the next slide is the announcement itself, the budget itself for this year. What we do is demonstrate here for each of those categories identified, the total dollars to achieve the milestones under each in FY26. Importantly, this is above and beyond the current level of budget availabilities. As you can see, these total this year, tracking down that figure of $445 million. Now, each year, what's also important, and Congress expects us to include in the budget, is an estimate of how much toward that funding is available from the completion of tasks that already have been funded. And this year, this is a large amount, $332 million. I should note this is a larger amount than we've had before because it now follows years after the large increases in budget, which institute so many new projects, many of which have now been completed. So our estimate for funds that will become available from completion of projects is that $332 million, and then the net of that, the additional resources needed above that to accomplish the goals of the national plan is $113 million. Next slide, please. Summarized here, then, this would bring the total Alzheimer's-related dementias budget for NIH to some $3.871 billion, plus $113 million for a new total of $3.984, or nearly $4 billion. Next, please. This is an illustration in the form of a pie diagram to show you just what you've already seen in the percent of budget that goes into these categories, and this is a format we've used each year. I won't go through these in detail as with the examples to follow, but these will be here for you to review. And the next slide, please. So we've organizing these narratives, as I've said, by categories into these 6 categories shown here. And in the next few slides, we'll go through briefly, but not in great detail, examples of each. In the interest of time, they'll all be there for you to examine, and happy to be discussing each of them. So the next slide shows you examples in the categories of epidemiology and population science, important identifying trends as well as risk factors that feed other areas of research. Disease mechanisms, another. This is the basic research at the molecular, biological, and behavioral levels of the mechanisms that underlie Alzheimer's and related dementias. Next slide. Importantly, the diagnostics, assessment, and disease monitoring. With biomarker development, this has become an important and expanded area of research, and leads to that next category of translational research and clinical interventions. These are the trials which bring to bear the fruits of all the basic and translational research that happen into trials and interventions. As we've talked about before, and happily detailed to the future, an increased number, diversity as we identify new targets and design interventions toward those targets using the emerging biomarkers. Next slide, please. Important area of dementia care and impact of disease, informed each year, but in particular by those years in which we've had a summit directed at that category. Research resources, these are some of the structures in place that help to enhance and support data resources, for example, some of those which serve and underserve all of the research carried out in this area. And then a cross-cutting area, noting international studies have received emphasis of late to translate the findings we have, both by learning from international experience and directing towards ultimate goals of providing the outcomes of research to an international population. There are a couple of narrative documents that I refer you to. The first of them, next slide, and the next, is the Dementia Progress Report. So going along with the bypass budget is a summary each year of NIH-funded dementia research advances from the prior years. The next slide is an example of some of those. Again, I will not read through them in detail, but these are just examples, and recommend you take some time to look through the narrative that describes these. The next slide is implementation tracking. So as I've presented to you, there are milestones, now something over 200 milestones, which detail, again, the accomplishments needed to achieve the goals of the national plan. For each of those, there are criteria for success. For each of those, there are progress reports and elements. And these are all in the form of an accessible database that's available to you. It's searchable for areas of interest, and is our attempt to be as transparent as we possibly can about the process that leads to these estimates, and to document what's required and what has been accomplished in pursuit of all of them. And then iDROP, similarly, iDROP, again, to remind you, is the International Alzheimer's database, is used globally. We had a recent update of this at the Alzheimer's Association International Congress last week, when international representatives get together, and they've been enormously responsive in contributing not just NIH research, not just U.S. research, but all the research that happens to allow us to best coordinate what's going on globally. Next slide, please. And again, just a couple of announcements before finishing. The next summit is in September 23rd to 25th. If registration still has some slots open, please, if you're interested in attending in person, do sign up. It'll also be hybrid with the opportunity to view it remotely. This one is entitled Building a Precision Medicine Research Enterprise, and relates to the fact that as we're learning more and more about the heterogeneity and specifics of what goes on in the course of normal brain development, aging, and abnormal pathologies, we're learning more and more to design precise approaches that recognize the factors, risk factors, and events in individuals. And just to note, it happens to be NIA's 50th anniversary. I invite you all to help celebrate. It's the creation of NIA, along with NINDS we'll be hearing from in just a moment, that forms the focus, though not exclusive, of what is an NIH-wide effort in Alzheimer's and Alzheimer's-related dementias research. And happy to turn over now to Frank.
Okay, thank you. The NINDS is proud to partner with NIA to achieve the goals of the national plan. And just as a reminder, we take the lead on the Alzheimer's disease-related dementias. So we lead on Lewy body dementia, vascular contributions to cognitive impairment and dementia, VCID, and frontotemporal dementia. as well as multi-etiology dementias. And so in 2023, we spent $443 million on these projects. Some of that is from base NINDS appropriations, as well as the AD/ADRD congressionally directed funds. With NIA and our triennial summits, we come up with research priorities. Since 2015, we've developed more than 90 funding opportunities to address the priorities that the summits and NIA together we determine. And those logos on the bottom just indicate some of the large consortia projects that we've helped support. And so I wanted to highlight just a couple of the success stories we have. So if you could take to the next slide. We had, in 2019, our summit had the priority for early detection of cognitive impairment and dementia, and we created a funding opportunity for that. And I didn't know when we picked this example that the PI on this study would be here presenting, but so I'll just summarize quickly that we helped support this 5-cog paradigm for early detection. And so it's an approach for screening in the primary care setting, quickly, easily implemented to get better dementia care actions. And the success is dramatic with the cohort compared to controls, and the PI is here. Varghese will tell you about that later. But this is easily implemented, and it's evidence-based approach for better clinical care for dementia, less than 5 minutes, and it's not culturally biased. So we're enthusiastic about that result. Next slide, please. Okay, just there we have an article about how there's a lot of enthusiasm about gene editing in dementia, especially after the CRISPR-Cas9 system was approved for sickle cell anemia last year. And so there's thoughts, obviously, in the case of autosomal dominant genetic disease, that maybe we could use this system for treatment, but even the thought that maybe for non-genetic forms, because so much is sporadic. And so there was work a few years ago showing that gene editing could be used to channel APP to a cleavage pathway, alpha cleavage, that doesn't generate the amyloidogenic amyloid beta protein. And so this could be a way that the gene editing could be used for Alzheimer's disease. And so we had a funding opportunity for optimization of genome editing, and the lead researcher on this, Shiboji Roy, with that funding, was able to take this work into an animal model of AD and show that APP could be cleaved in the animal model and down this alpha cleavage pathway and have a diminished, long-term diminished pathology of APP in that mouse model. And so we're excited to reissue this funding opportunity for genome editing therapeutics and ADRDs, and they're on the bottom square on the right. We also have a new opportunity in the pipeline for IND-enabling studies for genome editing in AD/ADRD. So next slide, please. So those are just two of our successes. We have 21 planned opportunities, funding initiatives in the pipeline now. These are all listed on our website, and of course we also support investigator-initiated projects and have the more generous pay line for those projects. Healthy research enterprise is going to include investigators coming up with their ideas beyond just the funding opportunities that we create. Lastly, I'll say, I mentioned some translational and clinical work. We're also invested in disease mechanisms and training and career, because we believe that to really advance the science and neurodegeneration, we need to invest in the workforce. And also, we support research resources for the entire community. So with that, thank you.
Excellent, thank you. It's been very educational. I can't wait to look at the slides, because the slides have those great links that we'll be able to refer to. We have now come to the point of a 5-minute break. So we're going to break right now. Thank you.
Produced by the U.S. Department of Health and Human Services.